surgery, Bloomfield Hills, Michigan. So very interesting case. This is a nice patient, 67 years of age, had left breast cancer and ended up having what is reconstruction done with a tissue expander followed by basically replacement with what are silicone implants just from 2021, so just 5 years ago. So she comes in with the complaints of capsular contracture on the left side, history of radiation on the left side, and all the symptoms that you can imagine of breast implant illness that she had complaints of, given her age, factoring that in, and she was not happy with her implants. So we talked about it. She comes from the state of Washington. And so this is her case, 100% capsulectomy. So I started off on the right side always, which is the non-cancer side, and as you will see, relatively large implant. The first thing I want to highlight here is, as you will see, this is the alloderm. You can see right here, this is the corner, this is cadaveric skin. You can see the puree orange appearance, i.e. this the dermis of the skin right here, which is the mesh. And then you can see some areas relatively very thin, some areas thick. Here's the cartilage part of the rib. Again, very extensive area of dissection, complete total capsule removal. As you can see right here, inflamed tissue removed as well on the side. It was inflamed, angry. There was some suture that was also removed along with this reconstruction that we will see shortly on the inside. So I'm going to go ahead and cut this open. And we'll see, I'm going to cut at the boundary of this alloderm so you can see. So anything foreign has to be removed. If you will, let's go to the left side for a second. You will see there were surgical clips that were removed. Alloderm removed. You can see extensive alloderm. And anything foreign, such as suture material, was also removed, such that the patient got all foreign material removed, especially in the proximity of the implant. So as I go in right here, you will see I'm going to cut right through this boundary, and you will see as I flip this open, this is the alloderm. Right here, alloderm that was used in reconstruction. This is your Mentor 595, just like the op note said. Intact implant just from 5 years ago. Officially, if you look at the guidelines from Mentor, for example, they will tell you get an MRI at year 3, and then every 2 years they're onward. So I'm going to go ahead and pull this open, and you will see you can see it's very subtle, but it's there. What is that? Leaching of the silicone. Not impressive, but still there. You have the Mentor 595 cc's written on the back, and intact implant, relatively very heavy. And again, you can see, look at this mesh right here. You can see, look right here, this is the suture material I was talking about. Right here, this green cord, if you will, that's running. I'm actually going to cut it out so you can see. Again, I don't like when this thick suture, which is braided, is in the proximity. As you can see, it's rubbing against the implant. So right here, I'm going to pull it out. Again, this is your suture material, ethibond. You can see that big knot. And suture granuloma right here. And all of this foreign material has been removed. Alloderm, and which is the cadaveric skin used in reconstruction almost 70-80% of the times. So anything foreign, you can see, look at this big cord-like structure right here. The suture looks like a internal worm, if you will, and they use it to reinforce. The patient actually said it herself, I feel like something is tugging my chest. And you can see, look how thin the capsule is. No matter how thin, this is that. You can see the hair follicles of that cadaveric skin, the alloderm that was used in reconstruction. So extensive amount of alloderm. And this is the right mastectomy paddle, skin paddle. You can see it's attenuated, thinned out. And this is just the dermis right here. A lot of tissue on the side removed for contouring purposes. And this will be going to pathology separately, as we'll talk about soon. So now I'm going to remove my top glove. The left side was the cancer side. Remember, I have sterile gloves. I'm going to get a representative sample of the what is the biofilm on the inside, if there is one. Here is the surgical clip. There's two of them. One was medial, one is lateral. And again, in the proximity of the implant, I don't like this. As you can see, if it can potentially rub against and poke. This is the contouring that I did on the side and then the middle part. I'm going to send this with the left mastectomy paddle skin tagged at 12 o'clock to orient it. This is the lateral, this is the medial, superior, inferior. And as you can see, look how thin and attenuated. This is the radiated side, such thin skin. So all of this compromised skin was indeed very much removed and contoured. Again, you'll see the extensive alloderm. I'm overall very happy and content with how the whole dissection went. This is in the 600 range. Again, a lot of dissection. The bigger the implant, the more the dissection, especially it's sitting over a lot of ribs. As I go in, you will see right here, I'm having a hard time cutting through the alloderm. That's how thick it is. And you can see that stickiness. So a 650, just like the op note said, 650 larger on the radiated side, and you will see, look at this very extensive amount of alloderm that was used. Look at this tissue right here is somewhat calcified as well on the inside. The entirety of the implant capsule tissue has been removed. You can see there is some fatty tissue here. If I cut open, all of this is inflamed. It does not look like healthy fat. And so all of this tissue was removed along in the proximity of the alloderm. So I'm going to put it right here. So the implants will be returned to the patient. Right and left capsules will be sent to pathology, rule out the rare BIAL, CD30 analysis, rule out lymphoma, rule out malignancy, rule out any abnormal pathology. Cultures for aerobic, anaerobic, and fungal. Right and left mastectomy skin pellets to be sent separately to pathology to rule out breast cancer given the history, rule out anything abnormal pathology, anything foreign, alloderm removed, surgical clips, Athabon suture, anything abnormal, irregular, questionable, out. Only good, healthy, viable tissue with a nice flat chest aesthetic closure. So the patient has the absolute peace of mind that all of this was removed. And in the manner of removing the capsule plus the implant, I incorporate what is the fascia of the pectoralis minor, fascia of the serratus anterior, periosteum, perichondrium, intercostal muscle fascia, anything that palpates abnormal such that all of that tissue ensures complete removal of the capsule. This surgery is all about the capsule and that inflamed tissue around, plus the foreign material, and certainly the implant that anyone can remove. So it's all about the capsule and the inflamed tissue around such that there is no inflammatory burden left behind. And we'll see what the pathologist says. Complete, comprehensive, detailed, meticulous, sincere, honest, respectful dissection. Basically, so there's no second guessing the process. Two things were done today. All of that bad tissue is removed, and number two, all of this bad tissue is going to be tested so we know what it is and what it is not, and the patient has the peace of mind that she knows what she signed up for, and she's certainly not only going to see this video, but most importantly, the most important video is the right chest wall and the left chest wall showing complete removal of the capsule, so that she has that peace of mind and contentment that everything was done in the manner as described, and which is part of the informed consent. This is Dr. Khan, Executive Plastic Surgeon.